Hello friends, today we are going to study about bronchial asthma. For bronchial asthma, we will use four type of drugs. First is bronchodilator, second is steroids, third is mast cell stabilizers, and fourth is IgE antibody or omalizumab. Now let's look for bronchodilators. In bronchodilator, we can use sympathomimetics, we can use parasympatholytics or phosphodiesterase inhibitors. First, sympathomimetics. In sympathomimetics, we will use beta 2 agonist, which will bronchodilate, which will dilate the bronchus. Examples of beta 2 agonists are salbutamol, terbutaline, terbutaline, salmeterol, and formoterol. These all drugs are given by inhalational route. Okay, so short acting drugs we will use in acute attacks. Long acting drugs we will use as prophylaxis or in management. Long acting drugs we will use for prophylaxis or management. Now, salmeterol, which is slow acting, we will use this slow acting salmeterol as prophylaxis. And formoterol, which is fast acting, we will use formoterol for acute attacks. There are some side effects also related with beta 2 agonist are, just remember, T T T T T T. First T, tachycardia. In high doses it stimulates beta 1 as well. Tremors, most common side effect. Tolerance, mainly with long acting beta 2 agonist. T wave changes because of hypokalemia, they cause hypokalemia, and hyperglycemia also. Now, second is parasympatholytics. We are studying bronchodilators. In bronchodilators, we studied sympathomimetics, beta 2 agonist. Now, parasympatholytics. In parasympatholytics, we will give M3 blockers. Examples of M3 blockers are ipratropium and tiotropium. These both drugs are given by inhalational route. They are drug of choice for acute attack in patient on beta blocker therapy. They produce slower response in bronchial asthma. Beta blocker therapy. Third is phosphodiesterase inhibitors. phosphodiesterase inhibitors. Phosphodiesterase inhibitor include theophylline, and aminophylline. They are given by orally or by intravenous route. They are not available for inhalational route. Both given by IV route or can give orally as well, but not as inhalational route, not through inhalational route. Mechanism: they inhibit phosphodiesterase, thereby they increase CAMP. So if increase in CAMP, that will lead to bronchodilation, which will lead to bronchodilation. Also, they are antagonist of adenosine A1 receptor. Adenosine A1 receptor antagonist. They can restore the activity of histone diacetylase, which is anti-inflammatory action. So, anti-inflammatory action. Adverse effect of phosphodiesterase are on GIT, nausea, vomiting, diarrhea; CNS, headache; cardio, arrhythmias, nausea, vomiting, diarrhea, headache, arrhythmias, because CMP stimulate hearts, so that this cause arrhythmias. Also diuresis, seizures, arrhythmias due to adenosine A1 antagonism. This GIT, headache and arrhythmia due to phosphodiesterase inhibition. Okay. Now we come on second, our steroids. First we studied about bronchodilators, sympathomimetics, parasympatholitics, phosphodiesterase inhibitors. Now we move on to steroids. Steroids, they are drug of choice for prophylaxis. They are also used in acute attack along with bronchodilators, because they increase bronchial response to salbutamol. They are given in okay. So examples of inhalational corticosteroids are beclomethasone, budesonide, fluticasone, flunisolide. And remember, only 5% of inhalational corticosteroids we give by inhalational route, only 5% reaches the bronchus, and rest 95% sticks on epithelium of respiratory pathway, which will lead to immunosuppression. And most common side effect because of immunosuppression is oropharyngeal candidiasis. We use topical nystatin to treat candidiasis, and also suggest gargling after every dose will prevent this side effect. Just suggest patient to gargle after taking inhalational corticosteroids. Okay. Now next is mast cell stabilizers. Mast cell stabilizers include sodium chromoglycate, sodium chromoglycate, nadochromyl. They are given inhalational by inhalational route, and we will use them as prophylaxis. So they are given by inhalational route. Next is our omalizumab or IgE antibody, IgE antagonist. These are monoclonal antibody against IgE. Example is omalizumab. This will be given by subcutaneous route. This is omalizumab antibody against IgE. Only used for prophylaxis. Given by subcutaneous route. We studied 4 types of drugs in bronchial asthma. First is bronchodilators. In bronchodilator, sympathomimetics, parasympatholytics, and phosphodiesterase inhibitors. Second, we studied steroids, beclomethasone, budesonide, fluticasone, and flunisolide also, and mast cell stabilizer. Examples of mast cell stabilizer: sodium chromoglycate, nadochromyl, and IgE antagonist. It is not agonist, it is antagonist, or IgE inhibitor, IgE antibody. This is all for today. Thank you.